Martin.
Thank you so much. I was a bit apprehensive. Normally when I stand in front of these stands that are opaque, people typically just see my head and ends up looking like a hologram, but I'm glad it's not just a head, I think, hopefully. My presentation is on a study that we did in Kenya, trying to understand how we can work with the private sector to improve access to HIV care. And a bit about Kenya. Sadly, we have the fourth largest population of people living with HIV, approximately 1.6 million people. Prevalence of about 100,000 new infections with a prevalence of about 6%. And although we have tried, compared to other developing countries, to have to scale up access to ART, if we are to get to 1990 goal, we still have a long way to go. And more so, especially now, once we start thinking about early initiation of ART. So we still have quite a long way to go. And that brings forth the discussions about, with the limited resources we have, do we have alternatives where we can look to? Either one way is to increase funding, but also see, can we be more efficient with the resources that we currently have? And that brings us to looking at what other partners can we bring on board? And naturally, being a private sector-focused project, we look at what can the private health sector in Kenya provide. And this slide shows a snapshot of the private health sector by the numbers, some numbers. And interestingly, just slightly about just over half of the facilities in Kenya are owned by private sector players, and 40% of the total health financing comes from the private sector, although this largely is out-of-pocket expenditure, and something definitely needs to be done about that. 22% of the total health expenditure is still spent in the private sector, and although when you look at HIV financing, about approximately 6%. So you have a strong presence of private health sector facilities, and definitely to that, the question of, are there ways that we can work with the private sector, definitely comes up. This slide looks at, what we have is a map of Nairobi, that is our capital city, and we have superimposed a representation of different facilities that are there. In blue is private facilities, in red, public facilities, and in what is a shade of yellow, the faith-based. Again, also, we can still consider them as a subsection of private facilities. And a recent national survey showed that in the urban areas, that's where we have a high number of people living with HIV. Indeed, in Nairobi, that's the county that has, on aggregate, the largest number of people living with HIV. And you find that also in the urban areas, you also have the well-off people. And a study also showed that there is quite a significant proportion of people who are who are well off, and they actually have HIV. And that leads us to the question, fine, we know that private sector has a very heavy presence. As you can see, there's a lot of blue and yellow, almost kind of overshadowing the red, the public facilities. So we know that the private sector has a very heavy presence in areas that, that has a large number of people living with HIV. So are there ways that we can work with the private sector? And what came up is that we realized, yes, let's look at how efficient. One way is, how can we look at efficiency? And with efficiency, that brings us to the next point of costing, and to understand which facilities can provide care at what cost, and who is seeking care at these facilities. Once you have costing data, you can be able to understand how much is it going to cost me if I'm going to use this large private sector presence. And also, since still quite a proportion of services, HIV services are offered to the private sector, you can understand who is using who is producing more with less, and essentially so who is being more efficient. With that in mind, we set out and did a costing study, and we collected data from 238 facilities. What you have there is a map of Kenya, and the geographical distributions there, the demarcations that you have are 47 counties. In blue, what you have is the counties where we essentially collected data. As you can see, we tried as much as possible to be spread across the country. This was a study done in collaboration with GIZ, and after collecting data, about 149 facilities were private facilities. Later on, down the line in 2014, we did the data analysis, and this time we visited, we did data verification, and we visited 30 private facilities. And we were able, even now at this instance, to collect data that we were initially unable to, and we were able to collect data that is specific to different services, with HIV being one of it. The data was analyzed through a tool we call MASH. MASH, it's an Excel-based tool. This is a quick overview of our costing approach. And on the first square, what we have is essentially what were the costs that providers were incurring. So our costing approach was from the provider perspective, and we broke it down into 3 cost buckets or cost drivers, so which was staff, drugs and clinical supplies, as well as indirect costs, where you have things like administration, laundry and such. And then we looked at what are these inputs that providers are having, what sort of what are we getting out of it? And we looked at outpatient visits, inpatient bed days, as well as service specific. And when we fed this data into our tool, MASH, we were able to get costs, specific costs, and these were costs that we could be able to tie these costs to specific facilities. What we have for the facility, in general, we had general costs, which were outpatient visit costs, inpatient bed days, and also for specific facilities, specific services that were of interest to us. For example, HIV, family planning. My presentation now just will focus only on outpatient visit costs as well as HIV services costs. This slide tries to what we are trying to portray here is that costs varied widely. On this axis, on the x-axis are costs in Kenya shillings, though we really won't delve into the actual costs. And what you have are clusters of facilities. We were able to get from 3 types of facilities. In Kenya, we have facilities in different levels. And what we have here are level 2, 3, and 4. Level 2 is a basic facility. It's called a dispensary, very basic outpatient primary health care. Level 3 is larger, will now have a nurse, a more experienced nurse, or what we call a clinical officer, very almost similar to a physician assistant, and may have some inpatient, basic inpatient services like delivery. And level 4 is a much larger facility where you have your medical officers, your general practitioners, and even have your specialized doctors and have more specialized inpatient services. In blue gives average costs of the different levels. For example, the first one has level 2, the second blue that has a red border is level 3, and level 4. And what you would anticipate is that as a facility gets moves from a level 2 to level 3, you would anticipate that the cost becomes higher. And interestingly, the costs were really, there was quite some fluctuation that we think was, we found that was quite interesting. When we delved deeper, we were able to generate the maximum and minimum. What we have there as the red bar. And so, for example, just taking the first bar for level 2 facilities, the top there shows you the maximum costs that we had at about 3,500 shillings. And the minimum, the lowest facility had average costs of about almost 200, 100, 200. So what are we trying to say here? We found that even within the same level of facilities, costs differed. So essentially, some facilities were incurring higher costs to produce one outpatient visit, and it went right across the different levels. So we move forward to the HIV-specific costs, and the first one is HCT, HIV counseling and testing. And it's a similar graph in the same manner, but here we just have level 2, 3, and 4. And here, as one would anticipate, the costs increase from level 2, 3, and 4, because you would assume that the larger facilities have more, may provide more care, may have more expensive staff, more specialist staff. Of note is that what you have in blue is the non-tested cost, and what you have on top in green was the actual cost of a kit. And you would anticipate that kit should be ideally equal across the different facilities. And it's, what came out is that, especially like for level 3, which were in between, had lower cost for the kits. And when we looked at this data further, it was driven by a number of things. We found that the level 4 and level 2 were having higher costs for the kits because they were doing a higher rate of double testing. And this could, and essentially they were using more kits. So this could be due to double testing as one of the things. And the first thing that comes to mind is that probably do they have a higher number of people who are testing positive, because by protocol, once you have your first test, you need to do a second one. So facilities that tended to have more positives would then tend to have more rates using more kits. Also, there are issues that need to be looked into. Were they using the kits in the right way, or had they stored the kits in the right way? Was there leakage of kits and such? The next one shows the costs, again, in a similar manner of the graph outlay. The cost of providing ART care to a patient per annum. And we are only able to get these results from 6 facilities. And what you can see is that, again, there is quite some variation. You really can't say that the facilities are providing care. And all these bars, the green bars are all distinct facilities. You really can't say that there is any trend or any pattern. At the far end is we got the cost from a recently released PEPFAR costing study that shows the average cost of providing care, ART care per patient, for low and middle income countries. And what is striking is that of the first 6 random facilities, only one is providing care at a higher than the average. So essentially asking questions about, is private sector necessarily higher? Do they incur higher costs? And they may not and it seems that private sector may not necessarily cost more than average cost of providing ART services. This is the similar graph to what we have, but now breaking it down for the 6 facilities, the cost of providing care, ART care per visit. And what I'm trying to bring out here is that the graph is the bar, like take for example, the first one is divided into 2. The total cost of providing care is about 1,930, but you see there is a green and a blue. The bulk of the cost, the green is the ART costs, and the blue is the non-ART, which is largely the cost of staff. And you see that here it's sort of the flip of what we had in testing, and it's anticipated that the bulk of the costs are coming from ART drugs. But still, again, it is not very, again, there's still a huge variation. So with this, what do we see? Is that ART and outpatient costs and testing costs vary across different facilities, and hence some facilities are more efficient than others, and some facilities, and there needs to be, and essentially, and also that private sector is not necessarily more expensive. And we are using these results to work with private sector and to help different facilities do benchmarking and also lobby for greater inclusion of private services, private sector services. Thank you.
We have time for one quick question, if there's one. Okay, otherwise.